Okay, so beginning with the heart part 2, we're going to look more microscopically now. We're going to look at the cardiac muscle, talk about a little bit of the anatomy and how that plays a role in physiology. Specifically, how does cardiac muscle conduct electrical signals, which is electrophysiology. So first of all, the heart's different in that we do not have to constantly think about when we want it to contract, when we want it to increase, when we want it to decrease, even though the brain can change these things. Okay, the heart itself can control itself. That's why we call it an autorhythmic organ. Okay, it exhibits autorhythmicity. So we will be discussing how it's able to do that. Now, one thing, cardiac muscle uses action potentials just like nerve impulses do and skeletal muscle contraction as well. However, cardiac muscle cells do not have to be stimulated. Okay, again, they can do it themselves. That's that autorhythmic nature of it. Cardiac muscle, though, because it's moving blood, and as we discussed in lab, blood moves because of pressure differentials. So if you cannot coordinate the activity of contraction for the different chambers of the heart, then blood will not flow properly through the heart and therefore to the rest of the body. So all of this activity must be coordinated. And there's some cells in the cardiac muscle that make up the wall that are special. We call these pacemaker cells. So first of all, if we just look at cardiac muscle and kind of compare what we know with skeletal muscle, first of all, the cardiac muscle cells are much smaller in nature. They also typically just have one nucleus per cell, which is going to be in the middle. They are arranged in sarcomeres, just like skeletal muscles. So you have alternating actin and myosin. When the actin and myosin get drawn closer together, the cardiac muscle shortens. You still have T-tubules that help make sure that the entire muscle contracts at the same time. However, inside cardiac muscle, we have additional structures that are actually going to help the current go from one cell to another. These are what we call gap junctions. Gap junctions are a type of cell junction that allow very small ions to pass from one to another. So essentially, if you depolarize one cell, okay, those ions, usually sodium, can very quickly pass to another and continue that depolarizing current. We also have what we call desmosomes. Desmosomes, remember, are a cell junction that helps cells not to be ripped apart. They're important with cells like cardiac muscle that undergo stress. These two structures together make up the very unique structure in cardiac muscle called an intercalated disc. Okay, so mainly the gap junctions will allow cardiac muscle cells to basically contract almost at the same time. Therefore, they can act as a unit. Okay, what we call a functional syncytium. And again, this is necessary so that blood can move through the heart chambers in the flow that it's meant to. So cardiac muscle has several different types of gated channels. Remember, if it's gated, something has to happen for that ion channel to open. So we have some voltage-gated sodium channels. So when we're going to change the electrical current voltage, those are going to open. We have these in pretty much almost all cardiac muscle cells except very certain pacemaker cells. Calcium ion channels, these are voltage-gated, but these are a little different. They have a time stamp on them. We also call them time-gated, meaning although they are initiated with voltage, they close after a short, brief period of time. And then all cardiac muscle cells have one, possibly more types of potassium ion channels, and these are ligand or chemically gated, so that's different. The rest of them are voltage gated. Some of them are voltage gated though. Okay, but the difference with potassium is that you can have the ligand gated as well. If you feel like you need to review some terms that we're going to be using here, I strongly suggest you do that. the next several slides, I like to actually kind of draw a cell and remind myself, you know, of the main ions that are going to be in higher concentrations outside of the cell versus those inside of the cell. Remember, channels are going to allow movement from high to low concentration. Pumps typically will allow it against concentration, or one solute might be going along concentration, the other might be going against. So the cardiac conduction system are these pacemaker cells, and the fact that they can spontaneously on their own depolarize. And these depolarizing currents lead to action potentials that can spread through the remaining of the cells. This is what we refer to as the cardiac conduction system. Specifically, the pacemaker cells that are embedded inside the heart, a lot of time will add the intrinsic conduction system. So action potentials, okay, that were generated in pacemaker cells will move to nearby cardiac muscle cells. These are the ones, most of the cells in the heart, we call these contractile cells. And they're able to transmit this electrical current through those intercalated discs that we mentioned earlier. So again, the gap junctions are going to allow that depolarizing current, the electrical activity, to move from one cell to another. Which, of course, action potential begins with depolarization, followed by repolarization. Again, the purpose of this, having all of the cells united, is so they act as a unit, a functional syncytium. Unlike skeletal, we don't want to have just a small amount or very large amount contract and at different times. Okay, we want the cells to be highly coordinated, so this allows them to be that. So the cells that make up the majority of the cardiac muscle cells that form the heart are contractile cells. So in here, just like we're used to seeing action potential, you're going to have a reversal briefly in membrane potential. So it's going to start negative, and then it's going to go positive, and eventually it's going to go back down. We will talk about the numbers are going to be a little different here than what we saw with neurons or a skeletal muscle fiber. Okay, so we talk about the steps that occur. Again, we're talking about cardiac muscle, and these are the contractile cells. Okay, so you have a depolarization phase that's very quickly. So because we have more sodium outside of the cell than in, sodium moves in. Okay, so we start at rest at a negative 85. So a huge influx of sodium depolarizes the membrane, and it's going to go to about a plus 20. It can go a little less than that. Then, basically, when you hit that plus 20, you're going to start the first part of the repolarization phase. We call it initial. So why we start to repolarize is because these sodium gates close. So we no longer have positive ions moving in. You do have the opening of potassium channels. Very small amount here. So we're losing positive ions from the inside to the outside. So you do see the membrane start to repolarize a little bit. However, this is unique to the contractile cells. You have this period where it's very slowly repolarizing. We call that the plateau phase. Why this occurs is because we've added another channel that we really haven't seen before with muscle that responds this way, calcium channels. So when you hit just a little below minus 20, these calcium voltage gated channels open. And because we have more calcium on the outside than the inside, we now have positive ions moving in. We still have potassium ions moving out. So you basically are just losing a tiny bit more potassium than you have calcium coming in. So you kind of flatten out there. Why this is so important, if we lengthen the depolarization phase, you are allowing the heart to fill with blood. You don't want your action potentials to be too close together with cardiac muscle, unlike you want skeletal muscle to be very fast. We're going to follow that with repolarization. So sodium channels are still closed, so we do not have positive ions moving in. We no longer have calcium ions moving in either. So the only thing that's moving here is going to be potassium, because we have more potassium inside than out. We are going to return back to our resting membrane potential. So that's what repolarization is. So again, the very important thing to point out here is that the plateau phase is very different. We did not have that in skeletal muscle. So with cardiac action potentials, if they only lasted about 1 to 5 milliseconds like skeletal muscle, then the resting heart rate would be about 15 times faster than it should be, which is way too fast. You're basically, again, not allowing adequate time for the heart to fill with blood. You need to allow it to fill, so when it contracts, there's actually something in it to move the blood. So it lengthens the cardiac action potential to about 200 to 300 milliseconds. So slows heart rate, allows the heart to fill with blood. So with skeletal muscle, or if it were, I know these numbers are a little different, but you have that very brief depolarization, immediate repolarization, technical little hyperpolarization, but it's very, very fast. Okay, again, we have and there is that small period of time, refractory period, where the cell cannot respond to any other subsequent action potentials. So notice we have this plateau that allows for the filling of blood in the heart. That also lengthens the refractory period immensely. Again, you do not want the heart having too many action potentials too close together. You have to allow it to have time to fill. Okay, so that was the contractile cells. The other cells, which are in very small amount, are what we call pacemaker cells. So contractile are 99. These only make up about 1%. But these are those highly specialized cells that have the autorhythmicity factor. There's 3 different types of these pacemaker cells that we're going to talk about. And again, their special ability is that they can generate their own action potential. There are no voltage gated channels, anything like that that's necessary to start this. They do it on their own. Again, we call these the cardiac conduction system, or intrinsic. Okay, so the pacemaker cells do work different than the contractile cells. First of all, the initial depolarization, where it was very rapid in the contractile, it's much slower here. And again, that's because they do not have those voltage gated channels like we did in the contractile cells. They also do not have the plateau phase. The membrane potential basically oscillates. It goes a little bit up and down. It never remains totally at resting level. It's in a cycle. So as the end of the first cycle is coming, that basically the end initiates the beginning. And so it's just a repeated event. We do have cation channels, but we're not really specific for which ones. And these are only found in these pacemaker cells. Okay, so a big difference again that we see here are very slow depolarization phase. There are no sodium gated channels. Okay, you do have these cation channels that cations can move in and out. But basically you have sodium and you have calcium on the outside. You have potassium on the inside. So you are bringing in more positive than is exiting. So that is why you see it go a little less negative to this more positive. Notice here in this pacemaker cells, we have a threshold. So as soon as you reach that negative 40, now you've reached the threshold in which we open calcium gated channels. So now you have a lot more positive ions entering inside the cell, which of course helps it to rapidly depolarize to about +10. Okay, repolarization. Again, notice we do not have a plateau here. You only have plateau with contractile cells. We're talking about the pacemaker cells here. So repolarization occurs the same. We're going to close the calcium gated channels, open potassium. Of course, potassium is going to go high to low concentration, so we're going to lose positive ions. So we're going to restore our resting membrane potential. Another little difference here, we have this what we call minimum potential phase. Basically here, these potassium channels stay open a little bit longer, so you have a little too much positive that leaks, so we get a little bit more negative than we were at rest. So we have hyperpolarization, and that hyperpolarization is actually what triggers the first step, which was the slow depolarization, which involved those non-specific cation channels. So again, this is a cycle. That's why it does not require the nervous system or nerve stimuli to begin. Okay, so the structures of the intrinsic system, we're about to briefly talk about those. So you have the pacemaker cells are formed primarily in your SA node and AV node, although the AV bundle has some as well. The SA node is going to be much faster than the other pacemaker cells. It's about 60 times faster. So it's what basically typically begins the cycle. These are made of, all of the yellow here is represented by nervous tissue. So these are bundles of axons that will very quickly help the electrical current spread. So not only do you have the intrinsic system that helps it spread, but remember you also have the intercalated disc between cardiac muscle cells as well. So the sinoatrial node will begin the contraction. And again, electrical activity to initiate contraction means we have to depolarize. So we're going to send a depolarizing current down to our atria. So the depolarization current will make the atria contract. We'll kind of save the rest of that for the cardiac cycle. Then it's going to stop shortly at the AV node or atrioventricular node. There's a brief pause for two reasons. There's actually less gap junctions here, and so electrical currents are slower. There's also a basically bundle of fibrous tissue that kind of wraps and helps separate the atria from the ventricles. We really want there to be a delay here because you want the ventricles to fill with blood before they contract. And so this allows for that. After that small delay, then the action potential will go down the AV bundle or bundle of His, and then into your right and left bundle branches. Notice there's small bundle branches that go ahead and go up in the papillary muscles there. Then starting at the apex of the heart, we start to call these Purkinje fibers, and Purkinje fibers will run in the papillary muscles as well. So the purpose of having some of these bundle branches that go into the papillary muscles are that you want these muscles to contract a little bit first. You already want the chordae tendineae being tight, making sure that this valve is closed. That way when the ventricle contracts, there's no way, okay, that blood's going to be able to exit there. So we want that to be tight. Just like we talked about in lab, you can see a significant thicker left ventricle because the systemic circuit has a lot more vessels than the pulmonary circuit. The fibers will actually be thicker on the left side of the heart because of that as well. There's more muscles there. Which part of the ventricle will begin contracting first? We actually want to contract it, like I said, papillary muscles, but ventricle specifically, the apex. So you want the apex to contract because we want blood to be forced upward. Not up into the atria, but up into the pulmonary trunk and the aorta. So essentially, each population of pacemaker cells can potentially start the cycle. However, again, the SA node typically does that. The group that depolarizes the fastest is the one that sets the heart rate. So that's why it's the SA node. So the other pacemaker cells will basically just pass the signal along. The AV node will also do the small delay. However, if something happens to the SA node, then they can take over and set the rhythm. So the SA node is known for generating the normal sinus rhythm that we have. If something is damaged, the AV node or Purkinje fibers can basically become these pacemaker cells that can generate an action potential. The Purkinje fibers, though, are not going to keep a heart rate that is really going to be enough to survive. So the AV node is the only one that can actually successfully set the rate of the heart, although it would be slower than it would be with the SA node. The SA node is about 60 times faster. The AV node is about 40, so it is slightly slower. So under normal conditions, assuming a person's healthy, again, the SA node is what will start the action potential. It's going to go very quickly through the other cells because of those gap junctions that are the main component of the intercalated discs. They're going to go to the AV node. Okay, it does this pretty quickly, 0.3 seconds. Again, once it reaches the AV node, it's going to slow down. Already talked about this. There's a lower number of gap junctions, and you have the fiber skeleton that's surrounding that AV bundle, and that slows down electrical current, stops it from being spread as well. Okay, the SA node delays. Again, that's to make sure that blood's going to flow the way that it needs to. The action potential then goes to the AV bundle, right and left bundle branches, and then the Purkinje fibers. So the tool that we use to basically read this electrical activity of the heart is an electrocardiogram, ECG, or sometimes we refer to it as the EKG as well. It works by placing electrodes on the surface of the skin, close to the chest, because that's where we're trying to read the electrical activity. And we could basically see the deflections, depolarization, repolarizations in this graph. Generally, ECG consists of 5 different waves. Okay, each wave represents an active depolarization or repolarization. So notice the wave indicates what the membrane current's going to do, not contraction. Of course, depolarization will lead to contraction. Repolarization will lead to relaxation. So this is a rough sketch of an EKG. So the different waves that we have. So first we have the P wave. So the P wave marks when the cells within the atria depolarize. The largest of the waves includes the QRS, we actually call it a complex. QRS. These are when the ventricles are depolarizing. So again, it technically is 3 different waves. The Q is actually this tiny little downward portion. The R is upwards, and the S is the downwards portion. If you remember, in an action potential, we have depolarization, a positive current. It's always followed by repolarization as it starts to get more negative. So this marks P wave is atrial depolarization. The S actually hides the atrial repolarization. So that's occurring while the ventricles are depolarizing, which again actually begins at the Q. And then we have the last wave, we call it a T wave. This indicates ventricular repolarization. So this is this upward, just like we should have the upward for the P wave. So in normal conditions, it should roughly look like this. So if someone has extra P waves, if it goes down too much, if it goes down again, if they're missing, maybe they don't always have a QRS after the P, they can read things about that. We call them dysarrhythmias, and possibly figure out what's going on with the patient. And we will look at a few of those. Okay, so this just goes through basically what I just talked about. So feel free to review this in your book. It's probably not a bad idea to draw it out either. There are periods between the waves. These represent important parts of the action potentials, or showing the spread of electrical activity between different chambers. So intervals include a component of at least one wave. Segments do not include any wave components. We'll talk about a few of the important intervals. So you have the R to R interval. This is the time between two successive R waves. Okay, so my R to R would basically be, if this is Q, this is R, so it would be from here to here. And typically when this is actually on a graphing paper, you have like little millimeter blocks, and they'll tell you how much time is represented by that. So basically this will give you information about how many times the heart's beating per minute. We refer to that as the heart rate. So that's beats per minute. The PR interval is the period from the beginning of the P wave, it's going to be here, to the beginning of the QRS complex. So that's the amount of time that it takes for the depolarization, that of course we know is started by the SA node, to actually go through the atria and get to the ventricles. Because as soon as the ventricles receive that, there's that small delay, then they're going to start relaying the signal down to the bundle branches. The QT interval is the time from the beginning of the QRS complex to the end of the T wave. This is the amount of time that the ventricles are receiving the action potential. So again, this represents depolarization, and this of course is going to be repolarization. Okay, so you can see the segments, the intervals. I might have a picture on the exam. I will let y'all know. I would definitely know at least where the important intervals that I wanted you to know, which was the QT, the R to R, and the P to R. Okay, if you feel like you would like to watch a video, very helpful. Again, Khan Academy, they always make some of the best videos for help with A&P. So talking about when the EKG or ECG shows something that's abnormal, okay, a disturbance. Call this a dysrhythmia. Or arrhythmia is probably a little bit more common. So disturbances in the heart rate. So this is the frequency. Bradycardia is any heart rate under 60 beats per minute. Tachycardia is a heart rate over 100 beats per minute. Normal is what we refer to as 75 beats per minute. Okay, so you can look at that as a comparison. Sinus tachycardia means that the person, their normal resting heart rate has that fast rhythm, where a person just can experience tachycardia on medications or when they have high blood pressure, when they're stressed, etc. And I should point out, the problem with sinus tachycardia is because you've sped up how often the heart's contracting, again, you've reduced how much time the heart has to fill with blood. So you can have disturbances in the pathways that the electrical current uses. These can be between the atria and the ventricles, or by a block through somewhere in the pathways, what's known as a heart block. And we're only going to talk about more important ones. So most common type of heart block is usually at the AV node. So what we see here is the P to R interval is longer than normal. due to an increased time for impulses to spread through the ventricles through the AV node. And also, what's probably easier to see here is that you have extra P waves. So what that means, if you have atrial depolarization through the AV node, AV bundle, you're supposed to pass that to the ventricles. So basically you skipped passing it to the ventricles here. Fibrillation is any time the electrical activity of the heart is erratic. Basically, it's so erratic they really can't distinguish it specifically. So it causes the heart to depolarize parts of it, others to contract when they're not supposed to. So the movement and flow of blood is definitely disruptive. You can kind of think about it as a bag full of earthworms kind of quivering. You know, again, the heart, you want each chamber to contract all at once. So if they're doing that at different times, that's not going to be an effective way to create blood pressure and therefore blood flow. So there is atrial fibrillation, which you definitely don't want, but that's not near as severe as ventricular fibrillation. Ventricular fibrillation is immediately life-threatening because the ventricles are what directly pump blood into the pulmonary and systemic circuits. So if this is going on, they will get defibrillators where they basically electrically shock your chest. That's going to depolarize all of the ventricular muscles at the exact same time. So basically they get into the refractory period where they're not responding to an action potential, and hopefully the person's SA node will basically see that there's a long period of time where there hasn't been an action potential generated, and it will resume a normal rhythm. Okay, so a little bit of review. When comparing cardiac muscle tissue to skeletal muscle, what is true? Both cardiac and skeletal are voluntary. Voluntary means conscious control. Of course, that's only skeletal. Skeletal would be controlled by somatic motor fibers. Cardiac's going to be by autonomic motor fibers. Skeletal muscle fibers are connected by intercalated discs. That's true of cardiac, not skeletal. Both types are striated. That's because of the alternating actin and myosin, the thin and thick types of protein. So that's true. Skeletal muscle fibers are shorter. Again, that is a characteristic of cardiac. And there are more mitochondria, and it should be cardiac. Yes, skeletal muscle contraction is important. However, the heart contraction is more important. So you want to make sure the heart has enough ATP to allow this to happen. So you want to make sure it can get oxygen, allow cellular respiration. That's why it's going to have more mitochondria. A skeletal muscle may undergo tetanus, but cardiac muscle cannot. Remember, tetanus is a sustained muscle contraction. That is true. We don't want cardiac muscle to be sustained because, again, you want a period of relaxation where the heart can fill. And remember, what tries to prevent that from occurring is that plateau stage, which has a longer refractory period. So actually, this is the next question. So which phase is the longest during an action potential in a ventricular contractile fiber? That's going to be the refractory. Because again, you want the ventricle to be able to have adequate time to fill with blood. That way when it contracts, there's ample amount of blood that's being pushed into your pulmonary and systemic circuits. So an ECG can help determine all of the following. A cause of chest pain, if it's because of an arrhythmia or a heart block, yes, absolutely. It will show if a heart attack's occurred because you're not going to have those synchronized waves. If the heart's enlarged, you're going to have longer intervals and segments between those. So you'll be able to see that on the EKG as well. If the conduction pathway is functioning normally, is the electrical current able to travel in a normal pathway? So obviously all of these determine the EKG. So all of these have something to do with the electrical activity of the heart, and that's what the EKG or ECG reads. Okay, which wave is matched correctly with the heart's activity? So the QRS complex would be ventricular depolarization and atrial repolarization. So that one's not true. P wave, neither one of those are true. That's true of the T wave. Ventricular depolarization is the QRS. So the ST segment are when the ventricles are depolarized. That is true.